Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Welcome to Well Said. I'm Dr. Ira Nash. Today we'll be discussing the fascinating topic of 3D bioprinting. 3D bioprinting is a way of creating three-dimensional structures out of living tissue or biological material. It holds tremendous potential to improve medical and surgical care from joint replacement to organ transplantation. I can tell you I'm looking forward to exploring this fascinating new technology with today's guest, Dr. Daniel Grande. Dr. Grande is the Assistant Vice President of Research Services at the Feinstein Institutes for Medical Research at Northwell Health. He is also a professor of molecular medicine and orthopedic surgery within the Institute of Bioelectronic Medicine at the Zucker School of Medicine at Hofstra Northwell and the Feinstein Institutes for Medical Research. And I'm delighted to welcome Daniel Grande to Well Said.
Thank you. It's a pleasure to be here today.
Before we dive into bioprinting, I'd like you to start with just an explanation of what conventional 3D printing is all about.
So 3D printing is a manufacturing process that creates a physical object from a digital model file. The technology works by adding layer upon layer of material to build up a complete object.
So that sounds a little Star Trek-ish. What sorts of materials are generally used for 3D printing?
So actually there are a number of different methodologies for accomplishing 3D printing, but the most common iteration or concept is using filaments that are usually plastic, or they can be PGA, polyglycolic acid, or PLA, polylactic acid, that can be melt extruded into a fine filament that can be laid down in a progressive manner to build up an object. So basically, any type of plastic object that you can think of, we can print for you.
And when you say print, I mean, most of us think about printing as ink on a page, but you're using the same word to describe the construction of a three-dimensional object, right?
Correct.
Is there a limitation in the sort of size or complexity of things that can be manufactured this way?
Yes. So when you think about macro or larger objects, we can actually, they have been printed, the things that have been printed include things like whole houses can actually be printed.
Whole houses?
Whole houses can be printed, 3D printed, yes, with large machinery and ways to rapidly polymerize or solidify concrete so that you could actually, in a day, manufacture a building structure. Now, when we think about medical devices or a use of 3D printing in a medical in a medical environment, we're talking about very small or high resolution objects that can be done in a very fine scale with a lot of detail, small detail, and really what is the limiting step in that is the size of where that extruded material comes out of the printer. So I think you can think of printing as being a method for, think of an inkjet printer, for instance, which was one of the prototypes for 3D bioprinting, which we'll get into, I guess. So that's been the focus of work in this area, is to try to manufacture things with high resolution and precision, and that's limited by the end result, or the aperture from which the 3D printing is extruded from.
Yeah. Now, you mentioned 3D printing large structures like houses. That requires a lot of different materials, right? I mean,
Correct.
okay, so 3D printing can use plastics, you mentioned. What about metals?
Yes, metals can also be used. There are special printers that can handle the temperatures needed to really think about melting metal. So you're talking about very high temperatures. We can also use other minerals such as calcium phosphates and things of that nature that can be used to print bone, for instance, as a scaffold.
Wow. Let's shift gears a little bit and go from the sort of generic principle of building a 3D structure through this technology to 3D bioprinting. So what is it that's different about bioprinting from this sort of general construction technique that we've been talking about?
So 3D bioprinting incorporates several other components that 3D printing alone does not. One is something called a bioink. And what we mean by that is a milieu in which living cells can be incorporated into such an ink and then printed to produce a three-dimensional structure that's living. So now you're talking about manufacturing, if you will, pieces of tissue like cartilage or bone from a 3D bio. So 3D bioprinting includes cells and a bioink plus an STL file or a stereolithography file that you can design how those cells and bioink will be designed to result in a three-dimensional object. So the printers and the CAD or computer-assisted design files that you design are then used to incorporate a living bioink, if you will, with cells and usually a polymer that's that has a certain cell compatibility with it. And you can imagine that cells that are being extruded through basically an inkjet type printer, it stresses those cells out. So like finding the right materials that can be not only extruded, but what we call shear thinning. So in other words, certain polymers under pressure of being in a syringe, for instance, which is really what you start with when you print in a bioprinting situation. The ability for that material, that bioink, to actually be able to be forced through a narrow syringe to get good resolution, it puts a certain amount of stress on cells.
Sure.
So that's been issues with how we deal with these structures. But certainly our data and others have shown that even if we lose a certain amount of cells due to cell death as a result of this rather stressful environment, we see that in the constructs that we do make that these are rapidly mitotically dividing, and the cells are happy in the milieu after the printing has taken place.
So you're printing at the same time, you're printing a structure and a living element within that structure so that you can create whatever unique shape you need to create.
Yes, that's correct.
We recently did a show devoted to minimally invasive approaches to treating structural heart disease. And one of the techniques that was discussed was using 3D printing to create models of a particular patient's heart that were based on CT and other imaging so the cardiologist can realistically plan or even practice their approach. But you're talking about going beyond creating something that fits a particular biological shape. You're actually talking about having living tissue in that biological shape. Is that correct?
Yes, that's correct. And so we as a group and certainly within the Northwell Health system have certainly worked with our clinician partners in providing them with, for instance, things that you mentioned in the sense of in the area of cardiac surgery. And so, for instance, in orthopedic surgery, we can model, for instance, if we're removing a tumor, we can print custom specific 3D patient-specific cutting guides to take that tumor out in a very precise manner, and then also use the inverse concept of using those same types of guides or that same design to cut a perfectly fitting allograft to take its place in a bone situation. We work with dentistry to develop 3D printed patient-specific drill guides for precise drilling and placement of dental implants. And then the same thing goes for total joint replacement, where we can make customized drill guides and cutting jigs, and we do that, and it saves. The 3D printing has really revolutionized the hospital, how things are done clinically, because we can now pre-bend plates and have jigs and cutting guides that will reduce surgical time, therefore reducing patient anesthesia time, et cetera.
Sure.
So that's been something that we've definitely worked on and have made major inroads in the health system. Now, as far as what we're doing in the bioprinting
let me get
arena,
back to that.
So we're doing with that is, for instance, we're making customized autografts or allografts, if you will, for bone and cartilage. So we can actually print a customized osteochondral plug. So in other words, a piece of bone and cartilage that would fit the contours of a patient's defect in their knee, for instance.
And when you say autologous, you're using the patient's own cells.
Correct, right. So we don't have any immune issues, and we can use bioinks that are compatible, such as collagen and alginate gels that will hold the cells in place. We can take we can take adipose-derived stem cells from the patient. So taking a little bit of adipose tissue from them,
fat.
Or fat, or bone marrow, culturing the stem cells within that, pushing them toward a certain phenotype, or a certain differentiation into chondrocytes, and then implanting those and layering those in a manner such that there's going to be a bone layer and then a cartilage layer, and so we could have both to treat a patient. And then additionally, we can use certain filaments that contain calcium carbonate, which is or calcium phosphate that's in bone, and use that as a scaffold to add cells to for large bone defects.
So that's fascinating. Why start with cartilage and bone?
Cartilage, the reason we start, first of all, cartilage has been, for me, as a long-time career regenerative medicine investigator, has been has been a holy grail of orthopedic surgery. For instance, prior to my starting my work on my PhD, the consensus in the orthopedic community was cartilage defects or injuries do not heal, and that's because cartilage is avascular and has no blood supply, no nerve supply. So there's not a normal sequela of repair that occurs, say, in the skin if you have a dermal wound in your skin.
Yeah, and just to be clear, that's why most people who get joint replacements, right? Because they've worn out their cartilage and they have an arthritic joint that's no longer smooth and it's bone on bone, and that hurts like hell.
Right, exactly. And that's usually as a result of an initial post-traumatic issue that occurred, of a trauma that occurred, and that sequela is this post-traumatic osteoarthritis, correct. But so cartilage is unique in that it has really only one cell type within the tissue. Okay. It's 85 to 90% extracellular material like collagen and proteoglycan, which is a large molecule that holds water in it. But basically only 10 to 15% of the tissue is cells, and those cells are responsible for manufacturing all that extracellular matrix. But because there's only one cell type, it's a rather, and I'm making it sound simplistic, but it's an easier tissue to recapitulate. So
Okay.
so that's the reason. And then I've always been interested in cartilage, but when we get down to really like some of the complexities of cartilage, there is a articular cartilage in the knee, for instance. There is a definitive cytoarchitecture. In other words, there is a certain formation or organization of the collagen fibers within that tissue. And so while we can certainly put chondrocytes within a gel to end up to a certain thickness to make new cartilage, where the ultimate goal is really to recapitulate the entire right. And so that's the future, and we can talk about that at a later date. But in addition, let me just say that in our health system, I was approached by our colleagues in ENT, otolaryngology, that work on trachea, which also has an interesting similar cartilage to the knee in that it's hyaline type cartilage. And they approached us several years ago in order to see if we could collaborate, and we actually put together 3D bioprinting of cartilage for the trachea, and have had several high impact journal articles that we've published. And we also, I'm sure you might be aware of this, we won the President's Award for Innovation several years ago in 2016 for that work. So
our listeners may not be familiar with that, but that's an internal award at Northwell Health for innovation in developing new technologies that could help a large number of patients. So let me just clarify something you said there. So it sounds to me like, if we go back to my earlier question about why cartilage, it sounds like the answer is because it's relatively straightforward compared to a lot of other tissues in the body. But even there's still a ways to go before you get something as good as the original, so to speak.
I would agree with that.
Could you just walk us through what the process looks like? So let's say you and your orthopedic colleagues have decided that a particular patient would benefit from having a 3D bioprinted joint surface created for a knee. How do you get from, Mrs. Jones needs this, to here it is, hand it to the orthopedic surgeon and have her put it in the knee?
So the first step would be to get some imaging done. And from that MRI, we now have within our health system, that thanks to our Department of Radiology, we have the ability to download from Allscripts a STL file, that's a stereolithography file, that can be used to help design as a basis a implant of that type. So at least we'll have what the contours are, what the dimensions are of the defect that we want to fill or heal. And then from there, what we could do is two of the following steps. One is take some adipose or fat tissue from that patient, or some bone marrow from their iliac crest, and then isolate those stem cells, culture them in conditions that would either promote a cartilage or a bone phenotype or differentiated state, and then have both bone and cartilage cells in syringes in our bioprinters, then incorporating a bioink, then have a base of bone laid down, printed, followed by the next layer of the chondrocytes or the cartilage cells in their bioink printed. And from there, we would take that construct that's been newly synthesized or newly printed into a media like a bioreactor. So in other words, a media with certain nutrients would be constantly bathed that construct.
So when you say media, you're talking about like a fluid bath that this thing can live in until it's ready to get put in the patient.
Exactly. And we would also ideally culture that in a condition that had a certain amount of hydrostatic pressure, so that the construct saw something reminiscent of what a mechanical load would be like in the human. And that allows the chondrocytes and bone cells is exquisitely tuned to mechanical loading. So once you start doing that, you would, loading them in a hydrodynamic fashion, you would see those cells manufacturing abundant matrix proteins that would render it much stronger. So then at that point, an arthroscopic or with a mini arthrotomy portal could be used to introduce that construct and perfectly fit into the defect in the joint. Now, what we want to do is we do know that cartilage, because by virtue of the fact that it's completely encased or encrypted and entombed, if you will, into its ECM, its extracellular matrix, its ability to interact with immunoglobulins from an immune cell, like in other words, a macrophage or another immune cell sentinel, we could actually use allograft chondrocytes from another patient.
All right, so let me just help translate a little bit of what you just said. So I think what you're saying is because of those living cells are kind of buried within this material that they themselves produce, it shields them from the body's immune response, and therefore you can actually use somebody else's cells to create this printed part and worry less about that being rejected by the recipient. Did I get that right?
That's 100% correct. Thank you for interpreting that for me, because I get very wrapped up in the minutia of it.
That's fine, but that's kind of my job here, so that's fine. So how long does that take? I mean, it sounds like a pretty involved process.
It is. It takes actually a couple of weeks to actually do that. But if you think about it, if you think about patients that have received similar things that I developed years ago, such as autologous chondrocyte transplantation, where you use your body's own chondrocytes to fill a defect, we find that the patients that have received that have gone on to 20 plus years of not having repaired their cartilage and not needing total joint replacement. So if you think about, if you could minimize the effects on the patient, such as, say, instead, if it eventually gets FDA approved that you can use allogenic from another donor source, you could have those cells ready to go, image the patient, start the process, and then have it much faster and less trauma to the patient, him or herself, because you're not taking either fat or bone marrow from that patient. So that's, I think, the future, and that will be something that will be in the future armamentarium of orthopedic surgeons. That's a very doable thing.
Yeah, well, that sounds great. I mean, I think what you're describing is something that not only fits better but works better, and is not a foreign piece of metal or plastic that's destined to itself wear out. How prevalent is this approach now? Is this something that's being done on kind of an everyday basis, or is this only under unusual circumstances?
Well, it's currently under very unusual circumstances. Now, the only one thing that we've done from a clinical perspective here is a trauma patient that sustained in an automobile accident, had her elbow sheared off, and the bone, there would be aged type of surgical cascade of events leading to a reconstruction of that patient. But the surgeon came to us and said, this is like a very unique setting for this, but we would like to use 3D printing to see if we can help this patient. And what we did was we took an MRI of the contralateral elbow, the other elbow, and made a mold that we filled it with we use to fill bone cement impregnated with antibiotics, and that surgeon placed that implant perfectly, a perfect match for that patient. As a matter of fact, she's so happy with it, she doesn't want the next series of reconstructions that would take that implant out and put an allograft in, because she's happy with it. So that's something that, but as far as that was a one-of type scenario. However, with this technology in particular, how to translate it into the clinic has been a challenge, I should say.
Well,
and
let me ask you about that.
Yes.
I imagine there are regulatory issues that stand in the way. I want to take us in the time remaining just to talk about the potential for this technology to create even more complex structures. I mean, you were very clear that you started with bone and cartilage because it's relatively homogeneous and you can get the structure pretty much the way it appears in nature. But what about printing something really complicated like a kidney or a heart?
So one of the key challenges for manufacturing, 3D bioprinting is also a form of additive manufacturing. It's similar to 3D printing, right? So one of the things, as we know in medicine, is that any vascularized tissue or organ needs to be within a certain distance. I think it's like a millimeter or 2 millimeters from a blood vessel, right? So vascularization of such implants needs to be at the forefront of developing larger organ, more complex organ systems. So actually, there's been a lot of work that's been done by other groups at Wake Forest Regenerative Medicine Institute down in the Carolinas, and other places where they've actually made livers, 3D bioprinted livers, kidneys, intestine. There is heart, skin, for instance, has been used. And one of the things there is a 3D printed skin that's used for complete, for complete coverage of a large wound, for instance. But what happens in those situations is, even though it's 3D printed and all, eventually it sloughs off, so it doesn't get incorporated. So what they're trying to do now is develop a way to vascularize it with a pedicle, and there's a pedicle meaning
we have to explain what we're talking about. So vascularize it meaning allow it to enjoy the blood supply of the patient in which it's being implanted.
Right.
Because all living tissue needs a blood supply.
A lot of development of the technology has been to figure out how to incorporate into a 3D printed, bioprinted structure or implant a way to provide a vascular tree. And that's been something that's been developed, and people are working on that as well. So with a combination with some of the more sophisticated bioprinters have, for instance, up to 9 different heads, so that you can manufacture up to, say, in some cases, say liver cells, you would have liver cells, then you would have a layer of fibroblasts, and to be a baseline, then you would have a layer of capillaries being printed, and so forth. And you could have each of those in different tubes or heads within the manufacturing facility of the bioprinter. And then you could also have certain things that are polymerized on UV light, or you could have a construct that's a composite of both. Because remember, if we're talking about soft tissues alone, you can imagine that if you keep building layer upon layer of soft gel-like materials, that there would be a lot of loss of resolution, as well as some top heavy, like if you would have things that wouldn't be. You have to build some
structure to this,
right? So So what we've done, like for instance, in the trachea, we remember we need for trachea. You need to live by breathing. So if that fails, that's a problem. So what we do is we incorporate a superstructure, or if you want to call it an infrastructure, of a lattice that can help provide some mechanical rigidity to a structure that's predominantly cell-based. You know what I mean? It's like you have different materials. You can make a composite. That's the future of these composites.
The challenges are clearly manifest here, but do you think that we're going to be seeing fully bioprinted implantable organs anytime soon?
I would say in the 10 to 20 year range, yes. Yeah. I mean, we're getting there. There are 3D printed things that have been FDA approved, but not bioprinted. Actually, the first bioprinted bone is a company called EpiBone, which got approval for a phase 1-2 trial. Even their group has to use a 3D printed scaffold and then use the patient's cells that they seed onto it. Yeah. And it's for the ramus of the angle of the jaw. It's a dental type bone implant. That's the closest that we see. With future successes in that realm, you're going to see more people investing in it and so forth.
Last question. So this has just been fascinating and eye-opening for me. If our listeners were interested in reading more, learning more about this, where would you direct them?
The International Society for Biofabrication. That's like a legitimately good resource. One company that makes a really good bioprinter and has been really at the forefront of bioprinting has been a company called CellInk, located in Sweden, but also has offices here. We upgraded to their BioX printer, which has really been working well for our projects here.
Dan Grande, thank you so much for joining us today.
You're very welcome. I'm glad to have been here. Thank you for the opportunity to talk to you.
For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.